Thank you for joining us for this episode. Today, we're joined by Dr. Erin Rueff, and we're going to be speaking about the improvement of your patient's comfort by adding astigmatism on the OI Show. Thanks again for joining us on this episode. Today, we are joined by Dr. Erin Rueff. How are you today, my friend?
I'm good. How are you?
I am awesome, and I am super stoked to get to hang out and learn about this topic with you because I've got dozens of questions, and I'm really excited about it. Before we get into the topic, I want the few people who don't know who you are to know more about you. So tell us a little bit about what you do, where you live, and anything else you think we should know.
Yeah. Well, my name's Erin Rueff. I'm currently the chief of the cornea and contact lens clinic at the Southern California College of Optometry at Marshall V. Ketchum University in Southern California. I'm an assistant professor there, so I teach in the clinic. I see patients there, and I also teach in the contact lens curriculum and in the basic science curriculum at SUCO. Before coming here, I trained at Ohio State and did a cornea and contact lens fellowship at Ohio State, and then stayed there for several years to teach. And I completed a PhD in vision science there as well. So before I came out west, I was a Midwest girl, but liking life out here on the West Coast.
What is visual science?
Vision science. Well, it's all science, all about vision. So that could be about ocular anatomy, physiology, studying pathology, ocular disease, optics, physics, all of it. So, the study of vision science can mean a whole lot depending on what your interests are.
But you already had a doctorate
I
in
did.
visual science. So why did you go get another one in
Yeah, it's a good
visual
question.
science?
Yeah, so I like a lot of optometrists, obviously
I'm
I got
sorry, I
my
don't mean that to be a rude
no,
question.
yeah, I'm just like a chronic overachiever, maybe my family. Yeah, so after I got my doctorate in optometry, or I guess as I was finishing up my OD, I was kind of feeling like just doing patient care, I still had some things I wanted to do, or some sort of things I was curious about and interested in. And so that's actually why I did the 2-year fellowship at Ohio State. And this would be a good time to plug that sort of unique fellowship, which
Is
is,
unique.
yeah, it's a residency essentially, in that you spend half your time seeing patients in whatever specialty you're assigned to or signed up for. But you also spend half of your time doing research and getting a master's degree and teaching. And so for me, that was a really great opportunity to flex my clinical muscles, but also get some experience in research. And ultimately that, when I finished that program, I still had some questions to answer and some things I was interested in. So that's why I went forward and continued with the PhD, which was probably the best decision I ever made. But that program, the fellowship, was really what kind of sort of propelled me into that. So I think it's a understood or maybe a misunderstood program, and a lot of people just don't know about it. And so is, again, really great opportunity.
Yes, and now you're doctor, which is
Yes.
even cooler. So now that you have answered all of the questions that you've ever had, because you continue to go and get more education on it, you are now teaching all of it. And I think maybe after you finished your doctorate, you decided that maybe you should actually make a lot of money answering the questions from then on. And now you do other research, right? And you're involved in patient care. And so you
Yeah.
still do what you did during your PhD,
Yeah.
but now you get to do it and make more money, which is awesome.
Make more money than I did as a PhD student, that's for sure.
Exactly.
Yeah.
Well, many of us have benefited from the research that you've done. Many people in industry have benefited from the research that you've done. And one of the things that, I've observed you talking about over the years is contact lens discomfort. And, that's a really old topic. I mean, when about 8 years ago, the contact lens dropout rate was right around 16 to 18%. And with advent of all these new contact lenses that have come out, we've improved that number to 16 to 18%. And we really haven't gone anywhere. And I think you have an area that you've looked into and you talk about that maybe maybe we need to look a little deeper into, and that is the visual discomfort side of things. Talk a little bit about how this all came about in this arena, right? We've talked about, pain and dryness and discomfort, but what about this visual discomfort?
Yeah, well, I completely agree with you. We've had all this, expansion in technology and improvement technology and the materials and the types of lenses we have, but discomfort is still such a huge problem in our wearers. And if you read any of the literature about contact lens discomfort, a lot of the conclusions about why someone might be experiencing discomfort are often inconclusive, and we don't know. And I think as a young doctor, as I was just starting kind of practicing on my own, especially within a contact lens specialty, I got it is really frustrating to kind of just be sort of randomly throwing solutions at a patient who's complaining of discomfort. And most of the time our solutions for discomfort.
You probably shouldn't throw contact lens solutions at patients.
Yes, that's true. I mean, that's why I stick with daily disposables. It helps me avoid that. But
randomly throwing solutions.
Randomly throwing solutions.
The
ones I'm most displeased with that week. So, I started to think there must be something else here. We always just say, oh, if you're uncomfortable, it's because your eyes are dry, or the lens is interacting with your ocular surface in a, not ideal way. But I started to think about how a lot of symptoms our patients complain of when they're uncomfortable are actually similar to just like general astigmatic symptoms, like fatigue, eye strain, symptoms that increase at the end of the day, that kind of thing. And this actually started when my graduate advisor, Melissa Bailey, said, hey, why don't we I have got this group of patients that are recruited for a dry eye study. Why don't we give them the CISS, which is a survey for convergence insufficiency, which you could argue is sort of a survey that measures visual fatigue kind of generally. And we found that these dry eye patients had high symptom scores on the dry eye survey, but those scores correlated with the CISS as well, which really shows that symptoms associated with dryness and ocular surface issues are very similar to symptoms that people experience when they have visual fatigue. And so I've done a lot of work since then looking at, how vision influences comfort. And there's also been work by other great researchers and colleagues in the field looking at how vision and vision-related issues influence contact lens discomfort. So clinically, how we can apply this and how we can use some of the evidence that we found is thinking about sort of maximally correcting our contact lens wearers. A few things that stand out to me when I think about maximizing vision when I am fitting contact lenses and addressing discomfort is, one, making sure I'm not over minusing my patients. So making sure that those myopes, especially your moderate to high myopes that often eat up extra minus, that you're not, over serving them when it comes to myopic prescriptions, because we know if you're overcorrected, that's going to affect your, accommodative demand and convergence demand. And considering how much we all focus and read and look up close all day long, over minusing your patients is just not the best practice.
So remind me of this. I know the answer, but I'm going to act like I don't. Adding more minus, how does that affect convergence?
Actually, might have misspoke there. It doesn't directly affect convergence, but it will affect your accommodative demand. So if when we over minus our myopes, they're going to have to accommodate more up close. Generally, we know that myopes need to converge more in contact lenses than in glasses. So that is just a base-in effect that the spectacle lens provides for your myopic spectacle and contact lens wearers when they're wearing glasses. They don't have to converge as much. So when you put your -7 myope in a contact lens, they will have a higher vergence demand than when they're wearing their glasses. So that high myope might experience vergence demands in their contact lenses that are more uncomfortable than they would be in their glasses. And they might misinterpret that for dryness, discomfort. They might just not wear contact lenses as much because they're having to converge
Yeah.
more. So
And
it's a
by over
delicate balance.
minusing them, it's affecting their ACA ratio, and we're substantially making it even more difficult for them,
Yes,
especially because they are challenging themselves with that convergence, and they have less of the accommodative ability to help them with that. And
exactly.
with the increased near demand that we have compared to way back when I went to optometry school, it's even so much more important on that. But Erin, here's the thing. When I take a patient and they've got a diopter cylinder, I don't want to correct it. So I just, give them a half a diopter extra minus. Are you telling me that I shouldn't do that?
I am telling you that you shouldn't do that. There's actually some really good evidence out there. A great study by Stephanie Cox a couple of years ago came out where they is a clinical trial where they compared low astigmatism, low toric lenses compared to spherical lenses in patients that had like average, like a diopter, maybe a little over a diopter or less of astigmatism. And while the vision was the same in both lenses, so the like acuity was essentially the same, what the patient read on the chart, the patient subjectively preferred the toric lens to the spherical lens. So I think that's a good takeaway for us as optometrists. It's really easy to just get caught up in our exam room chart and say, well, they're seeing 20/20 with both. But subjectively, what patients often prefer is very different than what we might expect based on just our exam room chart alone. That
But
same
it's an
study,
aspheric lens, right? So it compensates for all that cylinder. That's
I
the
don't think we can
other.
say that anymore, David. No, I don't think we can
Oh,
say
okay.
that. That might have been something, 10 or 15 years ago when the toric lenses we had weren't as good as the toric lenses we have now. But
Okay.
our resistance to prescribing toric lenses is probably more based on sort of old practices and assumptions we had about older toric technologies, and not based on the really good lenses that we have now available to us. So we really should be correcting those low astigmats. 75, I mean, I've even had some patients with a half diopter of astigmatism who prefer to have the toric lens over the spherical lens that has the spherical equivalent. So it's really something as a practitioner you just should be offering. If you see that patient you have in their manifest refraction and their autorefraction has a diopter, has 0.75 diopters of astigmatism, they can really visually, subjectively, and I would argue comfort-wise, benefit from a toric lens. That same study by Stephanie Cox, they gave those patients the CISS as well and found that patients had improved CISS scores with the toric lens compared to the soft spherical lens, indicating that their visual comfort was better with the toric lens.
Man, sister, I'm with you. I actually have written a lot of articles about over giving SIL rather than under giving SIL and
Mhm.
its substantial benefit on patients.
Yes.
And the fact that we do have a lot of old practices because we used to have to wait 20 minutes to correct people with their toric lenses. They'd have to settle. It took forever and it was a big challenge.
Exactly. Yep.
I mean, I literally just this morning wrote an article about how if a toric lens hasn't stabilized within a minute, you usually think it's not any good for the patient because we've become so, specific on our toric lenses. But it seems like our criteria for what a toric lens is supposed to do fits for its stability, but we don't go to toric lenses yet. It still hasn't become mainstream like you and I think that it should
Yep.
for all those half to three quarters of a diopter patients. And that I think what I need to hear from you is what are the things that we would hear our patients complain about if we had undercorrected their cylinder? They still see 20/20, right? But what
Mhm.
are the things maybe that those patients would complain about that those of us that are in the exam chair every day can be like, okay, I get it, right? Right. I'm hearing that complaint. And, I'm just thinking that the patient needs an ad or needs to stare at their computer less. Or what are some things that might be said?
Yeah, they might complain of kind of like non-specific discomfort complaints, because again, they're going to experience a type of eye strain that is not like, oh, I'm
Blurry.
correct. Yeah, it's not blur, but it's this sort of non-specific, like, I don't know, I don't love them. To be honest, a lot of times in my practice, I find these toric patients by, just looking at my data and saying, this person's been in a spherical lens for the last 5 years, but I'm picking up some SIL today, or I see in the last 3 years, we've included cylinder in their spectacle prescription, but not in their contact lenses. And that's when I throw in, why don't you try this toric lens, try the toric version. And I've had so many patients come in and come back and say, I wasn't that unhappy with my other lenses, but this was just the extra bump. And in my practice, I've really thought that's a way for me to differentiate myself from maybe an online retailer. We're always trying to compete with either, practices across the street or like a Hubble or an online retailer. They can't see that nuance in my patient's prescription like I can, and provide that extra sort of, bump in clarity that will enhance their vision, but also just enhance their sort of comfortableness in their lenses. You mentioned, sort of how you were talking about sort of, where we have sort of attitudes about old toric lenses. I think we have those same attitudes about presbyopic corrections and multifocal lenses as well. We assume multifocal technologies that maybe didn't serve us or our patients well 10 or 15 years ago still aren't going to serve us well today. And I found in my research and in my practice that multifocal lenses can be used early and often to treat discomfort in our contact lens wearers, both fully presbyopic contact lens wearers and those patients who maybe aren't presbyopic yet or emerging into presbyopia. Those same patients that have kind of that general discomfort that I was just describing in those maybe under-corrected astigmats, early presbyopes, emerging presbyopes, maybe just 30-somethings who are struggling with a lot of near work can benefit from a multifocal a little earlier in life or early on in presbyopia than we might practice normally.
Yeah. So do you know this number offhand of around about what percentage of the population has astigmatism?
About half of our contact lens wearers have enough astigmatism that we could correct it. So very generally, about 50% of all contact lens wearers have at least 0.75 diopters of cyl in at least one eye.
And what percentage of contact lens wearers are corrected with it?
Only about half of those are corrected. Yeah. So we're only serving about half of our patients. And, things like chair time, like it does not take any longer to fit a toric lens than it does a spherical lens. It really, and parameters, we have parameters for basically any prescription you would want. So it actually kind of boggles my mind that more people aren't fitting toric lenses because it's better for your practice, from a practice management standpoint to fit and prescribe toric lenses compared to spherical lenses. And again, it doesn't really take you any more time to do so. So yeah, it behooves everyone to fully correct astigmatism.
It does behoove them, that's for sure. That's such a great word. Okay, Dr. Rueff, before I let you go, I have to ask you about these weird visual corrections that are on my keratoconus patients after I put scleral lenses on them.
Oh boy, changing topic.
Most of them are coming from the back surface, but they're complaining of these very weird visual complaints, kind of like an uncorrected astigmatic patient would be. Do we have any science yet and that is related to this and correlation in unprescribed astigmats?
Like specifically to that, I don't know of like a specific, body of work that's looking specifically at that. Scleral lenses obviously do a great job of correcting refractive error in our scleral lens wearers. They can sometimes, oddly enough, induce higher order aberration. So while they can correct sort of the refractive error, they might, and induce may not be the best word there, but maybe alter or change existing higher order aberrations that we know our patients with irregular astigmatism have. And so that could be some of the sort of funky optics that those scleral lens patients are experiencing. Yeah. Also, like fog and halos and things in the tear film can contribute to that sort of unique visual experience.
And maybe you could speak to this, taking a corneal GP keratoconic patient and moving them over to a scleral carries with it some benefits and consequences visually. Can you speak to some of that and maybe why?
Um,
outside of fogging?
yeah. Well, so there's a list of pros and cons why you might choose a corneal lens over a scleral lens for a patient with keratoconus. At SCCO in our practice, we're very big proponents of the corneal GP and not letting that go by the wayside. Sclerals are sort of the hot topic in the last 5, 8, 10 years. But I think a corneal GP is always a good place to start with a patient with keratoconus. Generally, it's going to be the best sort of oxygen permeability, the best tear exchange. It's easier to handle, usually less expensive for a patient. But sometimes our patients progress to a point where corneal GP either isn't stable on the eye, isn't healthy for the eye. Maybe we're getting areas of touch, and that's when a scleral really can come in and take over. It's going to provide a lot of comfort, a lot of visual stability, has the ability to vault completely over the cornea. And so we don't have to worry as much, obviously, about bearing and touching and exacerbating scarring on the cornea. And scleral lenses can offer a lot of, bells and whistles visually on them that we don't have the luxury of having with the corneal GP, things like multifocals, some of those higher order aberration corrections a scleral lens can provide that sometimes a corneal GP, because it moves around, because it's not stable on the eye, can't provide. So some of the cons to a scleral lens, they're more expensive. They're going to be harder to handle. I think one con, maybe quote unquote con, is there's just a lot we don't know about scleral lenses and what their impact is physiologically on the eye sort of long term. I certainly don't think it's inherently negative, but it's an exciting area of research right now to see all the things we're learning about what actually is happening under a scleral lens. So yeah, there's a lot of reasons why you might choose a corneal or a scleral lens. You kind of have to think of all those pros and cons and your unique patient together as well, because all those things influence one another.
Yeah. Yeah. Well, Dr. Rueff, that was a fantastic podcast. I learned a lot. I think it was incredible for us talking about uncorrected visual issues that cause that discomfort that maybe we're just ignoring and thinking about, well, I'll change the lens because maybe that's your discomfort, right? So incredible information. Yeah.
Don't forget about vision. It's easy sometimes for as optometrists to get caught up in the disease and the pathology. And it's always good to remember sort of what our foundation is, and that's vision. We're better than anybody at correcting vision. So,
yes.
Yeah.
I agree with you, Doctor. Thank you. Absolutely. And thank you for joining us for this episode of the OI Show. Make sure to like and subscribe and join us again next time for other incredible contents on the OI Show. Hi, friends. This past December, I was asked to participate at the Ophthalmology Innovation Summit. This coming March 1st, the OIS is hosting the Ophthalmic Innovation Summit at SECO. And since I love what they're doing, I asked them if I might have a discount code for my podcast friends. If you use the discount code OI Podcast, that's the letters OI, the word podcast, you'll get $100 off of your registration. Again, that's OIPODCAST, OI Podcast at checkout.